axillary artery, and after that it enters the arm. It enters the arm and it becomes the brachial artery. It runs on the medial side of the arm and divides into radial and ulnar arteries. This knowledge is very essential. And the positive part is, in most of the individuals, in thinner individuals, we can palpate the artery from in entirety. It will be palpated, except in some obese individuals, or when there is some amount of edema, it's a little bit difficult. And the other point is, in these artery, median nerve will be very, very near to it. And if you know the anatomy of these brachial artery, we can find out the median nerve, which lies in proximity to the this brachial artery. And coming to the next important structure is the axillary nerve. From the acromion, from the tip of the acromion, the axillary nerve is located around, in and around about 6 centimeters. That up this 5 centimeters is the safe zone where we can pass wires or pins. And coming to these 2 centimeters, we need to be very careful, because of the axillary nerve will be coming, encircling from the posterior to the anterior aspect. And you see, this is the axillary nerve, and this is the safe zone, and this is the safe zone. And this is the axillary nerve, which is coming from the posterior aspect. And the ulnar nerve, it is lies on the medial aspect, and it enters the posterior intramuscular septum and goes behind the medial epicondyle. This also at the epicondyle, it is palpable, and above that, even though it is not palpable, we need to know the course of the ulnar nerve. And the radial nerve, it's not that direct route. Well, everyone knows anatomy perfect, and it's only a rehearsal. What I mean is from the posterior cord, it enters the posterior aspect and in the spiral groove, and it comes out of the spiral groove. It enters the anterior and intramuscular septum, and it will be on the lateral side. It will be on the lateral side of the arm, and it enters the forearm anterior to the lateral epicondyle. And this also, in thinner individuals, we can palpate it in the anterolateral aspect after it exits the spiral groove. So, and where this exits is, we can't say exactly, but it is about, it differs with the length of the humerus. So the best part is, if we want to have a safe procedure, the advised thing is mini open dissection for the shank pin application. And for the wires, we can go based on the anatomy. We need not open for the wires. For the shank pins, it is always advised mini open dissection, and under direct vision, it is better to pass, so as to have a safer application of the pins. And this is another important structure, long head of the biceps tendon in the groove, in the bicipital groove. This also we should not impinge while passing the wires or the pins. And it is the cuts. It is divided. Humerus is divided into 6 cuts, starting from proximal to distal. The proximal at this tubercular area between the greater and lesser tuberosities. And this here, how to pass the pins. Wire passing in nowadays, wire passing at this area, because of lot of pain complained by the patients, it is modified by Catani, and it is better to go for the shank pin application. And this is, one pin is passed transversely through the deltoid, and another is anterolateral to costrolateral aspect. You see, this is the deltoid muscle, and this is the infraspinatus, this is the subscapularis, and this is the coracoid process, and the tendon which is arising from the coracoid, and the conjoint tendon, coracobrachialis, and the short head of the biceps. And this is cut 2 at this level. This is the cut 2, and this is the axial sections. And here one again, so deltoid. This is the deltoid, and this is the Y pin is passed transversely, and this is anterolateral to the posterolateral aspect. And this is cut 3 at this level, mid shaft level. And here you see these are the structures. This is the triceps. This is the tricep. This is the left humerus. You see all the previous also, they are the left humerus. For your better understanding, this is the anterior aspect, this is the posterior aspect, and this is the lateral aspect. From the lateral side, we are passing the Shan's pins. Sorry, we are passing the Shan's pins, and the wire is also passed from within the safe zone, which is this is here. You see the radial nerve and the vessels here, and the vessels here, and you see these are the vessels. This is the radial, this is the ulnar nerve, this is the median nerve, and the brachial artery. And here the anatomy, cut 4, and this is in the lower, near to the lower middle third junction, and this is the cross-sectional anatomy, and this is the triceps posteriorly, one pin is passed, and anterolateral to posteromedial aspect. This is the ulnar nerve, this is the median nerve, and you see this is the musculocutaneous, and you see at this area we have where this radial nerve has entered the anterior compartment. This is the radial nerve. This is the radial nerve, and this is now the cut 5. Cut 5 is supracondylar region, and you see cut 5 is relatively a bit safer. What we need to cut 5, and here you see this is triceps. This is long head of triceps, and this is a brachialis muscle. This is the biceps brachii, and this is the radial nerve. And two Shan's pins were passed posteriorly, which is in the safe zone, and a wire is passed from anterolateral to posteromedial side and posterior to the ulnar nerve. And these pins or wires is a choice of the surgeon whether to use pins or wires. It depends on the expertise and the experience of the surgeon whether to go for pins or wires. But proximal humerus, it's many a times it is better to go for the Shan's pins application. And in the cut 6, this is the last one which you need to know. This is in the condylar area. This is the medial epicondyle, and this is the lateral epicondyle. This is the olecranon, and here one wire is passed parallel. This is the parallel to the joint from medial to the lateral aspect, medial epicondyle to the lateral epicondyle, and in a 30-degree inclination to the first wire from anterior to the medial epicondyle, it is passed in a posterolateral direction. And you see here, this is the ulnar nerve which is lying behind the medial epicondyle, and this is the median nerve. You see median nerve which has come medial to the brachial artery. In the first instance, if you see this one, it is lateral. This is lateral to the artery is nerve is lateral, but here coming here it has become medial to the brachial artery, and this is the radial nerve, and this is the tendon of the biceps tendon. This is the brachialis muscle, and this is the anconeus, and this is the anconeus muscle laterally, and this is the extensor muscles group. This is also the extensor. Okay, coming to the final conclusion, thorough knowledge of regional anatomy and acquaintance with the safe zones is very essential for a safe execution, which leads to a successful outcome of in the humerus Ilizarov surgery. Yes.
Any questions, or we move on with next talk by Professor Reddy?
I think, sir, we can move. There's no question on the net also.
So first you have to exit and then you have to restart the second.
Okay, exit.
Click to exit.
Slideshow.
Akansha, you share it, no?
Yes, sir, sure. Sir, you have to stop viewing your screens. Sir, you can click anywhere on the screen and it will exit automatically.
Wait. Let me do it. Yes, I've done it.
Yeah.
Now you can share again, sir.
Okay. So should I share your other PPT?
You can share.
So
Okay.
you can try, sir, because it'll be running. Yeah. Let Srinivas try once.
Okay.
Yeah. Yeah, 1 minute. I'll try. Yes, the next part, after knowing the safe zones, better go, it's operative principles, non-union humerus.
No, we cannot see your slides, sir.
Slides can't be seen.
Okay.
Sir, would you please double click on that, sir? It would probably open up.
Double click on non-union humerus, sir.
Okay. Right. Stop share. Wait.
First, open the slide in
Wait.
on the side, slide in the background. Then share the screen, sir.
Now?
Yeah, please go full screen, sir.
You are seeing?
Yes, sir. Please go full screen.
Okay. Right.
Perfect, sir.
Okay, this non-union, after having a thorough knowledge about the safe zones, and because the basic principles of wire passing, they do remain the same, not much. And so after that, the operative principles and what are the indications of in the non-unions. Any non-union where we can't go for internal fixation, where the surgeon is not confident of internal fixation, is an indication for Ilizarov non-union in humerus, non-union humerus by Ilizarov method. And what are some of the indications? As non-infective non-unions, in certain situations, we can go for Ilizarov, and infected forms, it becomes a absolute indication. With bone loss, it's again becomes a good indication. But in humerus, the difference in compared with lower limbs and the upper limbs is the indication for bone transport is 5 centimeters, but in lower limbs it is 2 centimeters. Of course, it depends on the choice of the surgeon and the patient. Even if it is less also, we can go for sometimes. And sometimes post-surgical failures, non-unions, which are not for internal fixation, we can go for the Ilizarov methodology of treatment. And the most important is the proper, thoroughly clinical assessment, preoperative assessment, clinical assessment, very essential for before resorting for the surgery. and optimization for the surgery. As usual, for any other surgery, we have to prepare the patient for surgery. And the next is we have to counsel the patient for the Ilizarov methodology because of its advantages, disadvantages, the need for Ilizarov, why we are going for Ilizarov, we have to explain them properly, and we have to give a good explanation regarding the necessity for Ilizarov, all the advantages, disadvantages, the fixator over the limb, and the positioning of the limb.
అయితే అంతకుముందు స్టెంటింగ్ అయింది బట్ ఇప్పుడు ఎల్ఈడి ఉంది 100% ఉంది అందుకే
and advantages and disadvantages and the regular dressings, pin side care, and the compression distraction protocol, everything we have to explain well in advance to the patient so that the compliance of the patient improves. If we counsel it properly, the compliance improves. And coming to the surgical procedure, for infected cases, we have to remove, as usual, implant has to be removed, and thorough wound debridement. We need to excise the dead bone, and we have to ream the medullary canal. And it depends, depending on the severity of the infection, we can choose a two-stage method or a single-stage method. If the infection is severe, it's many times better to go with a two-stage procedure. In the first stage, we can go with a simple external fixator to stabilize the limb, and in second stage, we can have a good plan, and we can go for Ilizarov method in the second stage, and if needed, we can go for corticotomy in the second stage. In the infection, when the infection is more, we can't go for corticotomy in the single stage, and then if the infection is less, we can go for a Ilizarov fixator application in the same sitting. And non-infective forms, fixator application, we can go in the single stage, and bone grafting is option of the surgeon. It's many times better to opt for bone grafting because it reduces the fixator time, and also it improves the confidence of the surgeon, and it reduces the healing time. So patient will be more compliant if we go for bone grafting. As these are recalcitrant forms, it's better to hasten the osteosynthesis. And bone transport, many a times it is not required as is as required in lower limbs, because even if it is 1 inch or 2 inch, there won't be much of functional discomfort or disturbance to the patient. So bone transport is not a common indication when coming to the Ilizarov and humerus. And the surgical steps is under general anesthesia or local, meaning regional anesthesia, and the table, the positioning, surgical step, the table positioning is to be taken care. We have to reverse the table. The head end should be made, in general, head end should be reversed so that the Shyam will be proper. We can visualize the Shyam properly, and Shyam to be kept in proper position. In this position here, we will be more, we will be operating from the lateral side. Shyam should come from the other side, from the lower limb side, it should come. And for we can use a olecranon traction device to have a better execution. We'll have better room. Otherwise, we can use 2 bolsters to have a space here, and second thing is, before that, we have to keep a small towel folded in between the 2 shoulder blades, and this one. And the surgical steps: proximal, 1 small Russian arch, and middle 1 ring, or depending on the situation, 1 or 2 full rings, and distally 1 5/8 ring. 5/8 ring is facilitates the range of motion of the elbow, so better to have a 5/8 ring which opens anteriorly. below elbow fixation, sometimes in supracondylar or fracture non-unions, we need to go when the bone is osteoporotic, we need to go for below elbow fixation. And the wires, olive wires, plain wires, and Schwann pins can be used. In humerus, many a times we can go for 1.5 wires, unlike 1.8 wires which we use in lower limbs. And exceptionally, in obese individuals, we can go for 1.8 wires. Olive wires can be used depending on the choice of the surgeon to add more stability to the fixation. And Schwann pins proximally will go for 6 mm Schwann pins, and distally and in the supracondylar region from the posterolateral to anteromedial aspect, we can go for a Schwann pin. That Schwann pin we can go with 5 mm Schwann pin. And this is the surgical steps. These are the surgical steps. And see, proximal arch, middle full ring, and this is a 5/8 ring which opens anteriorly to facilitate the range of motion of the elbow joint. And here at the level of the elbow, generally we do pass 3 wires, if not 2 wires plus 1 Schwann pin. And post-operative protocol, we need to have regular dressings and regular physio, shoulder movements, and elbow range of motion, and the follow-up. We need to ask the patient to come for regular follow-up. In the initial days, the patient has to screen. Okay. Initial days, especially when there is corticotomy, the patient has to come in a weekly intervals. Otherwise, in the initial days, 15 days, for about 2 months after that, monthly intervals, it is well and good. And the patient is advised to carry out the compression distraction protocols as advised by the surgeon. And this is about the operative procedure and cases.
Akansha.
Yes.
Yeah, this is about the operative procedure. And the cases are there.
Before that, sir, there are a few questions that Akansha is going to ask.
Yeah.
There are a few in the chat box.
Yes, sir. Sir, Dr. Praful Herod has asked, what is the size of the pins in the humerus for pediatrics and adults? If you can enlighten us, sir.
Size of the pins. There are 2 things. One is Ilizarov wires, and another is Schwann pins. Ilizarov wires 1.5 is quite sufficient in humerus. 1.5, and occasionally we can go for 1.8, especially when the patient is obese. We can go for 1.8, and Schwann pins proximally 6 mm is quite sufficient, and distally 5 mm is quite okay.
In pediatrics, sir?
Pediatric also 1 point. Generally, the indications of humerus Ilizarov in pediatrics is less. In adults itself is less, but in pediatrics we can go for 1.5, even in children.
Yes, sir. Sir, I think Jayant sir has a question.
No, I don't have a question. I was just wanting to ask Amar's opinion. Does he use a 6 mm pin in humerus, or he goes for a 4.5 mm?
6 mm proximally. Proximally.
Sir, I do use 6 mm, 5 mm both pin. In proximal metaphyseal region, 6 mm pin are good, but in soft at times one need to use 5 mm pin.
Yes, that is true. That is true.
Sir, there's a question from OrthoTV. Dr. Krishna Chaitanya has asked if you can briefly explain which pins to apply first, proximal most, distal most, or The order in which we should apply the pin, sir.
It is a generally I go for a progressive construct, distal to proximal. Distal to proximal. First first wire is the zone 6 actually. Zone 6 in the cut 6 is there, which I have described in the safe zones. Cut 6, the first wire is the transverse wire from medial epicondyle to the lateral epicondyle. After that, 30 degrees inclination anterior to the medial epicondyle, which passes from anteromedial to posterolateral, which exits just posterior to the lateral epicondyle. That is the second one. And the third wire is wire or shank spin we can use. That is a 5 mm shank spin, posterolateral, supracondylar region, posterolateral to anteromedial. At that point, radial nerve is already anterior to that spot, that area. So all the wires are in safe zones. This is the first 5/8 ring. After that, we'll construct a 5/8 ring. And for that, the tensioning is not more. 5/8 ring up to 70 or maximum of 90 kg tension is applied.
Thank you, sir. Sir, I would request if any of the senior faculty members who are here with us, if they would like to give their opinions or suggestions, please go ahead, sir.
Sir, I have a question, sir. Srinivas, sir.
Yeah.
Sir, in distal humerus fractures or non-union, what do you do to avoid elbow stiffness, sir? What is the protocol from your side, sir?
Yes, that is a good question. Right. We have to, the basic principle of passing wires is we have to stretch the muscle through which we are passing the wire. We have to stretch. We have to extend. While if you are passing through the bicep, we have to extend the elbow. If you are passing through the triceps, we have to stretch, means we have to flex the elbow. These are the basic principles where we follow everywhere, Ilizarov, so that after wire passage, we have a good excursion of the elbow movements.
And sir, next, sir, what is the protocol for activities of daily life post surgery for the elbow, sir?
Post surgery, meaning because the ring, it abuts the chest wall. So that what we do is a small cloth or a small pillow-like structure with 4 threads over it. They will tie to the chest so that it won't impinge the chest wall. So that we advise.
Sir, do you allow activities of daily life from the same limb, sir? Do small works to the patient after surgery?
As much as possible to his level best. We advise because it's a very stable fixation. We advise.
There's a question by Manish. I think Manish, you have to unmute.
Sir, good evening, sir.
Yeah, Manish.
Sir, very nice presentation, especially the coverage of the safe zones was very nice, sir. Sir, would like to take some practical tips from you as to really make sure that we don't injure any of those major nerves, sir. And have you had any experience of a post-op, say, radial nerve injury? And what has been the way, if you have had it, sir, then how have you tackled it, sir, after you found that the entire construct has been applied, sir?
Very practical thing you have asked. I had radial nerve palsies, but I correlate it to not to the wires. Generally, we do have very bad non-unions, infected non-unions, and long-standing non-unions. We need to do a lot of major exposure and all those. Many a times it is due to the retraction process, not due to the pins. It happens. We have radial nerve palsies, but they recovered well. Wires don't damage much. And for the shank spins, it is always better to have a mini open exposure and go for the passage of the shank spins to be safe and safe.
Thank you, sir. Thank you, sir.
And the other nerves, the anatomy is very clear. Only for the radial nerve,
Yes.
sometimes the exit it varies. Where it comes from to the anterolateral aspect, it is not very specific. And in non-unions, because of shortening, anatomy is highly variable.
Thank you, sir. It was a very good revision of the safe zone, sir. Thank you very much, sir.
Right.
Sir, I have a question.
Yeah.
Sir, just wanted to ask, in what conditions do you span at the elbow, sir, that you mentioned?
Yeah, especially in osteoporotic lower third fractures, when the fixation is not that stable in the condylar region or supracondylar region, we need to go for below elbow fixation. That a half ring, one pin in the ulna, and shan's pin in the ulna, and another in the radius. We had to go for below elbow fixation. That can be removed in about 2 to 3 months when the progression of the union is there.
Okay, sir. That was a very nice presentation, sir. Thank you, sir.
Now I go with the cases. Cases, Akansha,
Yes, sir.
you're having cases?
Yes, sir. I do, sir. If you would like, I can share my screen, sir.
Yeah, you share it.
Okay, sir. So please unshare your screen, sir.
Stop sharing.
Yes, sir.
Yes, right.
Sir,
Okay. I'm having about 4 cases I'm going to present you right now. After having the safe zones and the operative principles, the case presentation. And this is a non-infective form of non-union in a lady about 45 years age lady. She had 8 years old non-union. This is osteoporotic bone, and this is the type of non-union. See, is it like a pseudarthrosis? This is like a pseudarthrosis. I have opened it and I have found synovial fluid inside the non-union site. And you see the cartilage formation also. It's like a ball and socket type of joint it is. And the ends are resected and fixator is applied. Proximal half ring is applied with shan's pins, and a wire is also applied proximally, and middle ring, middle full ring. And one more thing is, what I do is, in order to maintain the reduction, I pass a small enders pin like that, so that what happens is our reduction becomes easier. It can be advised. It makes our job easier. After that, getting good reduction, better to have a small wire or a rush pin or an enders wire, which can be passed from distal to proximal from the lateral epicondyle. It's not that difficult, and it makes our job very easy. And this is a lady with the fixator on, and this is the range of motion. You can see comfortable range of motion with fixator. Shoulder also she can move perfectly, and this is united very nicely. And this is the post-operative or post-fixator removal range of motion. It's quite comfortable, quite okay. Next one, Akansha. And this is a very difficult non-union. It's a 12-year-old non-union with broken plate and with hypertrophy type of elephant type of ends are there, but very resistant. And plate removal, exposure, plate removal, resection of the ends, and the application of the fixator. And this took about generally the time period in these is nearly 8 to 9 months. It takes about for the fixator removal. And this again here also is a small rush pin is passed and united well. And this is the range of motion. It's a very obese person, and the dissection and the exposure also has become very difficult. Deep tissues were there. You had to go a very deeper level dissection, and this is the range of motion. Next. Next case. And this is an infected non-union. This is with a lot of comminution, and a wound is there with the infection. And in single stage, this is done. Proximal half ring and oblique supports were applied, and this is application. Next one. And united nicely. And generally, the patient comes for the removal. If he asks for the removal, I remove this pin. Otherwise, we can keep it like that. And this is the range of motion. Okay, next one. This is a supracondylar type of non-union. This is a closed one. In this case, actually, I removed it, but I have gone a below elbow fixation for about a couple of months. After that, I removed. And this is a thing. We do compress. You see the compression, otherwise it won't unite. You see the tenting of the wires, compression, good amount of compression, you see. And supracondylar non-union, united well. And you see the range of motion is quite fine. This lady, about 50 years old lady, and united well, good functional range obtained. Nice. Next one, Akansha. Thank you very much. And what I want to say, if we know the proper safe zones knowledge, and everyone knows how to pass wires, proper safe zone knowledge will make us life comfortable, and it takes less time. I can finish off in 1.5 or 1 hour 45 minutes. If you take the fixator time, it will be finished less than the time which will take for the tibia, because tibia we need to have a lot of fixation points, because tibia it is a load share. Load will be passed. We had to build the construct very rigid and stubborn. It should be. So in upper limb, it's we need not have that much that number of wires. Proximal 2 pins, middle 2 wires, and distal 3 wires. That is quite okay. It takes less time. Only thing is we should be confident of the anatomy and the safe zones.
Any questions from the audience?
So there's a question from Dr. Praful. So he is asking, sir, how many days are required for humerus non-union to unite in general, sir?
It takes, it will be more. Minimum 6 months, maximum it will be in 9 months.
Sir, one question. The previous 2 cases, the broken plate and the pseudo-arthrotic non-union, were
Yes,
they
sir.
infected or per se infected initially and then went into non-union?
History-wise, they are not infected.
Okay. If they are not infected, I just suppose they can be plated.
They are osteoporotic.
Yeah.
And the second one, it is having the bone contour is not proper. The second one, which one, broken plate.
Yeah.
It was a little bit difficult one.
Okay.
So one common question for the youngsters, sir. Sir, in humerus non-union case, how much duration you keep the frame on so that we don't avoid the refracture?
There's a lot of refracture chances if you remove the frame early.
Exactly.
How long do you want to keep it? How long will you like to keep beyond achieving union for preventing refractures?
Right, sir.
Yeah, we have to confirmed. We should have a confidence that it is united for sound union. We need to achieve a sound union. All the 4 cortices we will take AP view, lateral view, oblique views, and also we will have a clinical testing also. Then only we'll remove the fixator. Thorough checkup, clinical as well as radiological. And the fixator removal also is not will be done most of the times in a phasic manner. On outpatient basis. except in children, it is removed in outpatient in the clinic itself.
So what is the average duration of the ring on, sir?
Duration of the rings.
Rings, sir. So how many months are you keep the rings in a case of an average duration?
Sir answered 6 to 8 months, roughly.
6 to 8-9 months.
Yeah, I want to add, Shamshul, after removal of the frame, I give a brace to the patient, a FCB type, a humerus FCB, with a metallic stud on one of the sides, that is on the lateral aspect, and tied medially. It's so contoured well that even if the patient falls or does some rotatory movements, it will not refracture. Even if it is very solid union, I am confirmed about the union, still I give that.
Okay. To ensure.
Yeah, that is a vital point, sir. It's very important for the instance.
So I have one question.
Yes.
Hello.
Praful sir on fire.
Yeah. So in the lower limb, we make the patients walk, and that will have a trampoline kind of effect every time the patient walks or does his daily activity. So what about the upper limb? So how much compression do you maintain, and do you compress this on and off again in the whole period? 6 to 9 months when we are keeping it.
Yeah, upper limb, it's a non-weight bearing. No, we will
Right.
advise activities as much as possible he can do. Generally, we advise more of the joint movements and minimal day-to-day activities. Minimal day-to-day activities, whatever possible, we'll ask him to do to his level best. That is the first thing. And compression in general for all non-unions, it is preferable to have a biological type of compression rather than acute compression. Biological means if they are both the ends are in contact, I'll ask the patient to go for compression 1/4 millimeter once daily until the wires start tenting.
Okay.
Start tenting. So I feel that is the adequate compression. That is quite okay. I'll stop at that point.
Okay, and no further compression during that entire period. After that,
no. That is the if
you don't have to.
That point will stop.
Okay.
Accordion rhythm, that depends on the situation. If it is not progressing.
Okay. Right. Thank you, sir.
Right.
Okay. Shall we start with the second speaker?
So, sir, we don't have any more questions, sir.
Okay, so I invite Professor Gowtham CK for his presentation, and before that I'll give a brief introduction of Professor Gowtham. He is HOD and Senior Consultant at Continental Hospital, Hyderabad. It's not moving. Akansha,
Yes.
the slides aren't moving.
Sir, should I?
Okay. Dr. Gowtham has done his MBBS in 97 and MS Orthopedics in 2001 from BLDEA Medical College, MCS from Dundee, MRCS from Edinburgh. Then he got a board certification from the European Board in 2016, worked with MEOT at Chennai and Tirupati from 2003 to 2005, Bird Hospital. Then he went back to UK for his trials with Riddingtons and Harton NHS Trust Hospital, followed by Bolton NHS Foundation Trust and Royal Manchester Children's Hospital for Charity, St. Helens, a lot of overseas experience. And then he did his fellowship from Kurugan from 14 to 16, and then Bari Ilizarov Center, Dhaka. He did fellowship in Indo-British Hospital, Vijayawada, and now is presently working as Director and Chief Consultant at Continental Hospital, Hyderabad. We welcome Dr. Gowtham to ASAMI family, as recently joined as a member of ASAMI India, and these are few of his presentations. I'll stop my screen share and invite him for his presentation.
Come on.
Good evening, sir.
How to share this one? I have to open this.
At the bottom, you will find a share screen option in green.
Yes, yes. Yeah. Yeah, Kasha. Coming.
Sir, please switch on your video, sir, if possible.
Yeah. Is this one? Start video. Screen. Yeah. Screen?
Yes.
Screen. Yeah. Start broadcast. Yeah. So where is my PowerPoint? Yeah. Starting. Are you getting the video?
No, sir. Just open your keynote, sir.
Key. PowerPoint, I did everything.
Yeah.
Okay,
Screen is seen.
1 minute. PowerPoint. Where is that? Yes. Yeah, open. Can you share my
It's visible, sir.
visible? Yeah. I'll open 1 minute. Yeah.
Yes.
Sorry for my.
No issues, sir. You can just go on the top and then go full screen. Play mode.
Yes. Are you able to see this one?
Yes, sir. Visible, sir.
It's clear.
Yeah. Good evening to all seniors and friends and ladies and gentlemen. Already, sir introduced me, and basically I'm a arthroplasty primary and revision hip and knee surgeon with Scopy. Then before I'm coming to India, one of my consultant told me that my mentor actually go and learn Ilizarov. It's very important. So then I developed the interest in Ilizarov and went to Kurgan, then with Professor Bari, and started doing. And what I feel personally, every youngster should know is not that he is going to do any great things, but whatever he faces any complications, non-union, mal-union, or anything, open fractures, he can comfortably do himself. And I'm telling you, after doing these Ilizarov till now, almost from 2017 I started, results are wonderful. And I love to do Ilizarov only when it is indicated. So we'll start the case now. This is one of the nasty case when I joined here in Continental Hospital in 2022, September, almost it's a year. I left my own setup in Indo-British Vijay and came here. And this gentleman is a worker in a factory, and there was a blast injury. And you can see clearly that elbow is completely shattered at pieces and it's open, and radial head also dislocated, and soft tissue injury. And you can see the suit everywhere and burn marks, and also he had a mandible fracture on that side. This gentleman was admitted in another corporate hospital for 4 days, and they are going to embark on above elbow amputation. Then they came to know that I do all these cases, and they brought here, and I said, okay, I can fix it and I can get reasonable functional level. So before that, we'll talk about blast injuries. What are bomb blast injuries? They are divided into almost 4 types, like primary blast injuries, secondary injuries, tertiary blast injuries, quaternary injuries. These injuries mainly because of the primary one is which is very near, people who are very near. The shock wave will causes the massive injury, which causes fractures and amputations, crush injuries, and even compartment syndromes. Secondary injuries are most common extremity blast injuries. Tertiary ones are traumatic amputations, fractures, soft tissue injuries. Quaternary injuries are burns. Next, and again, primary one is, as we discussed, the casualties close to explosion, like air-containing organs like middle ear, lungs, and bowel will get a rupture and injured first. And secondary blast injuries are caused by flying objects, like penetrating injuries are most common cause of death. Tertiary blast are whole body or limbs are propelled by shock wave, individual are thrown against the fixed objects. Quaternary blasts refers to all explosion-related injuries, illness, diseases after these primary, secondary blast injuries. What the patient will have the complications and everything are the quaternary blasts. And extremity blast injuries are quite common in secondary blast injuries. And secondary blast injuries are more severe and they're prone for infection because of severe comminution and exposure to the outside like mud or roadside injuries or farm injuries or military injuries. Coming to this one, you can see this patient, he had a mandible fracture and also zygomatic fracture. And this one, I'll play some videos are there. You can see videos, very interesting. Can you hear? Or you can see that radius is completely came out and ulna, proximal ulna is almost shattered, and only he could able to move his fingers, and remaining everything is in big time chaos. And, can you hear anything? Anything video or no? Yeah.
Yeah.
Audible, sir.
Audible.
Just one small request, sir. Sir, at the top right corner, there is a triangle that points to the right-hand side. If you may click on that, then maybe we can have full screen, sir.
That one?
Yes, sir. Yes, sir.
Yeah, you can hear, no? Clearly, yeah. Okay.
Audible, sir.
Yeah, thank you. Yeah, what's next? What do you want to do? So, ATLS, the basic thing, you need to make sure when bomb blast is so severe and he has shattered everything, we need to make sure his life-threatening injury should be dealt first. Then coming to stabilize the patient and the limb, and then get the investigations done, and multidisciplinary approach. What normally we do when the patient comes here, we'll take a pics and send it to the plastic surgeon. And also we will alert the vascular surgeon if at all there is a injury to the brachial artery at its junction to repair when we are doing the procedure. So multidisciplinary team approach is very important, and counseling the patient and attenders and stabilize the limb. And for last very important thing is pray to the Mother Nature, pray to help healing the fracture. So ATLS consists of airway and cervical spine control, breathing and ventilation, circulation and hemorrhage control C, disability, neurological status, and exposure completely undress the patient to check whether we are missing any other injuries. Stabilization of the limb. Once the life-threatening conditions have been treated, then plan for reconstruction of bone and soft tissue can be dealt, assessing the viability of the limb. 5 P's, all of us know: pain, pulselessness, pallor, paresis, and paralysis. And in this type of case, capillary filling is to check is very difficult to interpret. So urgent Doppler examination will help us. And angiography should be performed to make sure the adequate perfusion and circulation is intact. So you can see this clearly. You can see the radius is out, and all the ulnar bones, proximal ulnar bones are shattered and pieces, and you can see all the muscles are exposed and soot everywhere, and burns, and all the skin is peeled off. So management of severe open fractures, as we know that BOS and BOPRAS protocol, IV antibiotics, ideally within 3 hours of injury. Vascular and neurological status of the limb is assessed regularly. Vascular impairment requires immediate surgery, ideally within 3 to 4 hours. That's where the multidisciplinary approach comes into role. And maximum acceptable delay of 6 hours of warm ischemia. Compartment syndrome also required immediate surgery, and urgent surgery is needed if wound is heavily contaminated by marine, agriculture, and sewage matter. And Coming to combined orthopedic and plastic teams are involved and clearly documented. And the wound is handled only to remove grass contamination and to allow photography, then covered in a saline-soaked gauze and an impermeable film to prevent desiccation. You should not use the betadine because it is clearly mentioned betadine delays the bone healing and also it is not good for the soft tissues as well. So now the guidelines are just clean thoroughly and just put the saline-soaked gauze. The limb should be splintered. And if definitive skeletal and soft tissue reconstruction is not to be undertaken in single stage, the foam dressing, vacuum foam dressing or antibiotic bead pouch is applied until definitive surgery. And as all we know that definitive skeletal stabilization and wound cover is achieved within 24 hours and should not exceed more than a week. And all we know that Gastello classification for open fractures. And pertaining to this injury, it is 3B, Gastello type 3B injury. And coming to Sharin classification, it's open fractures with contamination, and it is coming around a grade 2. And I've done the angiogram. Before doing that, you can see 3D CT scan with the angiogram. Brachial, radial are intact. So there is no threat to the vascularity, but we can see clearly that ulnar comminuted fracture and ulnar shaft fracture with radial head dislocation. So these are the pictures of angiogram, and I'll show you each and everything. I've taken some videos, sorry. I'll go back. In the theater, we took him to theater immediately in the night, and so
we
took
are
him to
doing a
theater
complex
and documenting
Gastello
everything,
type
taking
3B,
video of it.
blast injury. You can see that all the suit
And
around the
given him
muscles, and you can see the
supraclavicular block. Can you hear something? What's happening?
Surrounding the
Akansha,
wound, and
can you
also radius is exposed. This wound was kept like that for about 2 days in another corporate hospital and came here.
Okay,
Our plan
that's
is to
So,
stabilize it with Ilizarov. And,
just I'm explaining what
and
I'm
also
going to do, that
bone transport of
cleaning
ulna
and
and
thorough
later
merciless
the
debridement
plastics to cover
of
this.
dead tissues
see how
which
it
are
goes.
there,
Thank you.
and cleaning with almost 9 liters of saline.
We are doing a very complex.
And this is very important step. So we check the viability of the soft tissue.
Of the muscles.
How we check
So
the viability of
just I'm
soft
taking a
tissue?
cut.
Take your diathermy and just
Very
touch
important,
this
you need to
muscle tissue.
Yeah,
If it contracts,
muscle is
then it is viable.
contracting.
If it is not contracted,
Here
then
it is
we need
very
to
little,
completely
but here it's okay.
merciless
Here it's
debridement. You need to debride
And
all the soft
here
tissue
also
out.
it is
So
contracting.
I checked all the
Contracting.
soft
So
tissues,
majority of the muscles are okay.
whether they are viable
We'll see
or
how
not.
it goes. This is the best test to check the viability of the muscle. Thank you very much.
And started doing the
Thorough
debridement,
with
thorough
almost
debridement
9
of all the
liters of
tissues. You can
normal
see that
saline.
all
I
the
think you
suit
might
and
have seen
everything is
the
gone, and the muscle looks
wound before-
healthy
before-
and it
before
bleeds,
now you are seeing
and also it
thorough
contracts
merciless debridement.
when
Everything
we
is
touch
bleeding
with
well.
the
We have
diathermy.
already
Okay.
checked the viability of the muscle.
You can
Muscle
see
is
it's very
contracting.
clean
Now we'll
and
see what
then
we can do with the bone and
next step.
fix the. We are
So it comes next, passing the applying the Ilizarov frame. Already Dr. Reddy clearly mentioned about the safe zones. So here, while passing these wires, early wires and plain wires, we need to know that ulnar nerve is below the medial epicondyle, and you got the brachial artery and also the posterior intraosseous and superficial radial nerves. When it coming to the superficial radial nerve, just above the wrist, you should be very careful when you're passing the wire into the radius, and also at the wrist. And then again, the posterior interosseous nerve, which is very close to the proximal part of the radius. So all these this anatomy is very important while passing the wires. And again, brachial artery and ulnar radial arteries, very proximity to the ulna. But only good thing is that we can, when you know the safe zones, as Dr. Reddy clearly mentioned in the humerus, we can successfully pass the wires and do the surgery. And this is how the Shyam picture. So I reduced the elbow first, then reassessed the position. So you can see that radius is straight aligned to the capitulum, and the proximal part of the ulna is still in trochlear groove. Then the thing is that here the proximal comminuted fracture of the ulna and also shaft of the ulna is also present. So first I stabilized with the wire and tried to connect those pieces which are still holding with the soft tissue. I don't want to remove all the pieces, take away. Whichever is holding with the soft tissues, I kept it intact. Then applied the frame, the distal humerus and also proximal ulna, and stabilized the fracture. And this is what here, because, sorry, I'll go back. And here, 1 minute, I'll try to play this. Sorry. Here, you can see that I applied a large frame because there are two things. One is I want to put a vac. That's why I didn't put any rod there. So I left a space for the vac application. And also in future, if there is any compartment syndrome, I need to go and do the fasciotomy. So if I put the small rings, I may not be having the space to perform. So thinking all those things, applied a bit of large ring, and the proximal ring which I put in the humerus, I've taken out within 6 weeks and started mobilizing his elbow. And ironically, this fellow is a worker, so the company has paid him till I applied and stabilized his hand. After that, sometimes he disappeared and again reappeared in the hospital. I'll show you the remaining slides. So this is what I did. And
Guys, we have finished almost the forearm reconstruction. As you know that they had a blast, and you can see that all thoroughly debrided and merciless debridement. And now we stabilized his elbow, which is dislocated, and fracture also beautifully compressed. And now we are going to put a vac. For the vac, I have not put any rods here. I kept a space for the vac, and it's absolutely beautiful reconstruction. I think he's going to save his limb, and he will do absolutely
so,
fine. Thank you.
You can see, with the vac, the wound is beautifully healed, and then he disappeared completely because of vitamin M deficiency. So that company never supported him. So he disappeared and went to ESI hospital to get a skin grafting, successfully skin grafting done. Wound healed very well, and he came to me again. I removed the proximal ring and manipulated, and he started going to physiotherapy. This is after removing the ring. I removed the ring also, and I manipulated his elbow. And you can see this now. He came recently.
सीधा करो, bend करो, सीधा करो, right, okay. Wrist.
He got his fingers back, absolutely his pinch power and everything. He started working now.
Close करो, very good.
And he's able to manage his all activities without any problem.
Cow.
And he's eating. He's taking bath as well with that hand.
Very good. Excellent. Well done. Well done. Well done.
Yeah. That's all. Thank you very much.
Thank you, sir. That was a very inspiring talk and presentation as well. There's a question, sir, from Praful, sir. He's asking regarding
Yes.
development process, whether you have used any peroxide, and in general, can we use peroxide?
Hydrogen peroxide we can use, but see, these hydrogen peroxide causes delayed bone healing if you put into the bones. What we use is hydrogen peroxide normally when we, to control the bleeding, especially we use in the femoral canal, when you put the process cementing technique to get that honeycomb appearance of your medullary canal where the cement can integrate very well. So there we use normally betadine, and this hydrogen peroxide is not wise to use. Good clean, nice clean, thorough cleaning is very good. You can see now, this is the example. He didn't have any sinus, no infection, anything, absolutely fine. You don't need to put all those things. That's what I feel.
So
Sir,
can you see
do you have the final X-ray photo, sir, of the?
can you see the final?
Yeah, X-rays. 1 minute. They are there. I'll show you 1 minute.
Yeah.
X-rays. 1 minute. I'll go. 1 minute. Huh? Please wait. I'll show you final X-rays. Where is this fellow final X-rays? He came to hospital. Commission. 1 minute. Just wait.
Sir, in the meantime, I would like to
Yeah.
request faculty Rabindranath sir and Raju Iyengar sir if they have any input to give, sir.
Where is his X-rays?
Stop sharing.
Yes, sir. Please go ahead. Rabindranath sir, please go ahead. Good evening.
The fellow has come to our hospital early after the time. He is not fit to a flight. The part is done by us, and then he disappeared from us again. Can you hear me now?
Your voice is little on the lower intensity side, sir.
Hello?
Yes, sir. Better, sir.
Yeah, the fellow, I remember this fellow in my ward. We have done the drafting part of it.
Oh, thank you very much, sir. Thank you.
And I may not agree with you. Hydrogen peroxide is going to delay the healing process. No, never delays. In fact, when there's a greasy wound, peroxide is a good agent for cleansing the wound. You really enjoy it when you apply peroxide and then use the wax, pulse wax. It really does a fantastic job. That's one thing. And we have the radiograph, post-op radiograph.
I'm checking, sir. Just I'm checking. It is there.
Anyway, Gowtham, one question.
Yes, sir.
If not X-ray, how did you manage the gap in the ulna?
Ulnar gap still there, but the comminuted fracture healed. He didn't come for that. I told him that we'll do the bone transport and we'll get it healed, but this fellow didn't agree for it. I'll put you the X-ray. I've taken the X-ray. 1 minute. I'm checking that. You agree on the X-ray? Ulnar X-ray.
Raju sir, do you have any comments to give, sir? Any suggestions, inputs?
And sir, one question is why the elbow frame is not in flexion. I think, or I suppose it should be in flexion when, or 90-degree flexion when we are putting a across elbow frame.
Yes.
Great.
Because elbow flexion, because when I'm putting flexion, the joint is coming out because medial lateral collateral ligament is gone, and this one, what you call lateral
elbow is stable in flexion, never in extension.
Yeah. That is the way thing.
You always immobilize the elbow in flexion.
Yeah, because flexion is what needed.
As he develops stiffness of the elbow, a straight elbow is useless than a curved elbow.
Yeah. Yes.
So, elbow should always be immobilized in flexion, and the radiocapitular joint is stable in flexion, and supination of the forearm. And since it's comminuted fracture ulna, I don't think there's any problem in healing of the ulna if there is no infection. Since it looks like there is no infection, it must have healed without any.
I'm sending the X. Akansha, can you post the text? I've sent it to you.
Yeah, sure, sir.
Yeah, that is the present picture of his.
Just a minute, sir.
This used to be common scenario when we were in Usmania General Hospital. We used to get at least one in a month. Very common. All these are side sweep injuries. We call them as side sweep injuries. Fellow projects pops his elbow outside the bus, and then something knocks off the whole soft tissues. Very common injuries in Usmania Hospital.
Did you get the X-ray?
Yeah, got it, sir. Sir, is my screen visible?
Yes.
Yes,
Going
that is the present. That is the present X-ray, and
Perhaps I may not agree with your circulars whites in a compound injury like that.
Also, sir, I also do not agree with circulars because in open injury, there is always a periosteal and soft tissue damage. With the encircling, probably we are constricting the vascularity more.
Dr. Gowtham.
Yes, sir.
Yeah, that movement is a spurious movement which is taking place not at the elbow, truly at the elbow joint. It is at the fracture non-union site and again at the radio-humerocapitular joint. That movement which you have shown.
Yes, Srinivas, the radiocapital joint is part of elbow joint, isn't it?
Yeah, it's okay, but this one.
The movement is occurring at elbow.
Humero-ulnar joint. Humero-ulnar joint.
Yeah, it's occurring at the elbow only, but there's abnormality in the anteroposterior direction at the
no. We have to transport that. See, the proximal, that communicated fragments are, there's a gap, but that the shaft has healed very well. I told him that we need to do the bone transport and we need to do that, but that fellow didn't agree for it. So those are the constraints.
He's able to do his daily activity.
Absolutely, he's doing his daily activity. He's back to work. He's happy. He doesn't have any pain.
Don't touch
so that is the. He's already in his job.
Elbow joint.
Okay.
Okay, sir. Sir, we'll proceed to our next case presentation now by Dr. Kuldeep Parmar from Gujarat. So I'll stop sharing my screen, sir, and then Kuldeep sir can take over, please. Thank you so much, Gowtham sir, for your case presentation.
Thank you very much. Thank you.
Thank you, Akansha and Telangana State and ASAMI India for allowing me to present a case on humerus gap non-union, or rather a gap fracture with a bone loss in humerus. It was not presented to me as late as we expect. It was presented to me in a 2 weeks span of a time. So I practice in Rajkot, Saurashtra region of Gujarat. So this was a 28-year-old male. He had open inside-out injury, had a lower third humerus fracture with bone loss, and was treated with X-fix elsewhere. Here is the CT scan. Initially was done, that piece was almost straying outside, so excised by the primary surgeons, and they just fix it with a 2 distal humerus shunt pin and 2 shaft humerus shunt pin. So I did a ring construct, 1 5x8 ring in the proximal humerus, 1 full ring in middle, 1 full ring in lower third of the elbow, and 1 5x8 ring at just the condyles of the humerus. And that's how it was done. I did a shaft corticotomy and not rather the metaphyseal epiphyseal corticotomy. But still it went with a good regenerate. I had used 3 wires in the last 2 ring block for the distal humerus. Once when it came down, I was not very keen and was not able to open because of the two rings at the distal smaller fragment. So with the posterior approach, I hardly went up to the non-union side and put in a graft. I was not happy with the graft placement and the visualization. So, but he is functionally, he was okay. He was getting some range of elbow motions and supination, pronation, you can appreciate. But at 4.5 months, 5.5 months, I did, because of the proximity of the rings, I had to take the Shyam views, and where it was not showing union. And also the patient was starting pin loosening, so the pin site infection more at the elbow site, stiffness, losing her previous range of motion. So I opted, now let us, and the region rate was around 75 to 80% of consolidating. So I thought, let us remove it all and put in a plate and regraft the non-union side. So at 8 months and probably 6.5 months from the previous grafting within the rings, I did a dual plating and bone grafting and went up to the regenerate, above the regenerate into the proximal humerus and put in a screw. It was dually plate. And at 12 months, you can see the well healing. This is the functional outcome. 2 months post plating and bone grafting. This is 4 months post bone grafting. We are still in contact. This was my earlier case in 2019. This was the first case, but we are still in contact. He can drive bike and he's doing his all daily activities. So what I learned was 2 rings, yes, we always expect, but at the time of bone graft, I could have removed the lower third ring and just keep a 1 ring distally, could have used just 1 ring distally, because after the docking, the construct would have been stable. It will be intrinsically stable. So I would have, the rings would have been only 3 rings, but I kept the 4 ring that could have been changed. Thank you. Any question? I will be happy to answer.
So that was a very nice case presentation. So Dr. Praful has a question for you. He is asking, do you do plating at the same setting as the fixator removal? And if so, then are there any chances of infection, sir?
Yeah. So what I did, I removed the fixator, put him in a aegis lab for 7 to 10 days, and then I had done the plating.
If anybody would like to ask any questions, or Raju sir, Ravinath sir, if you would like to share your inputs. Manish sir, would you like to say something? Please do.
Humerus is one bone which behaves very humorously. The gap is less than 1 inch or 1.5 inches. I prefer to go for acute docking. And a short arm is not going to matter much for his lively activity.
So, I have a question, sir. Can you take us through your set of complications as and when you encounter any? Kuldeep sir, I just wanted to ask, do you take us through your series of complications or any issues that you had when you were doing the case during this bone transport, and what was the rhythm at which you were doing it, sir?
It was 1 mm per day. It was as 3 weeks and 4 weeks, I was sure that the tube is forming, so I kept on it for 1 mm per day. Though it was diphyseal, but the as we all know, the vascularity in humerus is abundant. So it was not an issue. It was the stiffness in the and the pin site infection in the distal wires at the later stage of the treatment, because the internal docking and internal support was not stable enough to make it a one bone unit. So that leads to wire loosening, and the wire rings were not working for me. Then I had to opt for a plating, because I also want that I do not want to keep it longer, because as I come to know that his elbow range of motion is decreasing because of the wire showing the infection. I opted for plate, because the preventing the elbow range of motion was also that much important, because I have got the length, I have got the bone stock. Why not 2 plates? So I went in for the. This could have been well been done in a ring fixator if I would remove the lower from top third ring.
Okay, sir.
Yeah, because it was my first case. I do in this way. Now I know that what better if next time I had to do. I may not require plate.
Indeed.
What is your protocol for a frame hygiene, Dr. Kuldeep? What do you advise for frame hygiene?
Frame hygiene, sir. We from Mumbai fellows, buddy. We all advise, sir, bathing and daily pin side dressing with just a simple boiled water. And yes, we need a sterile gauze piece, is that, but we allow washing with the soap, and everyday cleaning we advise the pin side once the stitches are removed, and we advise daily pin side dressing. So we advise patient to use a routine drinking water, advise them to boil in a large container of around 2 to 2.5 liters, and put in a small bowl also. So 15 minutes of boiling, that usually sterilize it. We advise them to have a hand wash and get the sterilized gauze piece. That is one thing we ask, and we advise them to do daily pin side dressing. We teach them in a first few days in the hospital. Then they do when I'm competent enough that he can easily do the pin side dressing. Then I discharge the patient. And stitch dressing we advise to be get it done by the local orthopedic surgeon or the orthopedic surgeon we know. And if that is not feasible, we call them by 3 days or 5 days. But they bathe, they do everything, daily cleaning.
So I think the basic purpose motive is to train the patients, all the patients in a case of humerus frame. Yeah. If it is a non-compound frame, so to allow and promote doing all the activities of daily life, like cutting vegetables, doing household activities, taking. I allow my patient to drive the bike also many times. If the construct is good, so the constructs have to be very, very important. Yeah. It has to be a very stable frame. The stable frame is important. Patient care is, as Dr. Kuldeep said, is very, very important. So we have to allow the patient to do activities of daily life so that a good healing is at the end.
And that is one thing for all young surgeons to motivate the patient, that a surgeon's job is always to keep from putting in frame to removal of frame, but 70% of job is being done by patient. So they have to be that had to be in their mind that yes, I have to be focused and constantly doing my job as good as the surgeon is doing.
Yes,
patient they are not doing the finger movement, they are not doing the ankle range of motion, if they are not preventing the equinus in the night or in the radial nerve palsy, they are not using the pin, then the function is not going to be there. So it is always motivating them and realizing them it is partly their job and it is partly our job as well. Then only
that is very important, because otherwise the patient is very scared putting a big ring and they don't do any movement to come back with a stiff shoulder and elbow and finger. So to promote that, it is a normal, you can do everything.
Like equinus, sir. Whatever equinus I have done, I think if I remember, 80 to 90% has been hospital acquired, because we don't give it in a dorsiflexion or a dorsiflexion screen.
A foot frame,
Almost all equinus what I have done by far now, it was due to the mismanagement.
Maximum case you can see in a case of normal fixator.
If the tibia is put in a foot is being put in a tibial frame of external fixator, or the simple below knee splint would have prevented the equinus. So our job is also as equal to the patient's job.
So my patients, whenever they came in a follow-up, I just asked them to put on a stool, a chair, lift a stool, so that they must have confidence.
Yeah.
Sir, do you give them a brace in the post-operative period? after you remove the Ilizarov, sir?
Yes, here I had an internal splint, so I didn't need to put in external splint. Otherwise, I would have. I do always in femur, in tibia. 3 months, it doesn't make much difference because the uses of my pin are tapered sans pins, 6 mm tapered sans pins. They are bigger hole. Okay, so sometimes that can lead to a stress riser and a fracture from that side. So why not a 3 months of a brace?
Yes, that is very important. Protecting is always.
Yes, and patient is all moving and all activities are allowed from day one of removal with the brace.
Sir, I would like to request Dr. Manish Prasad and Ravinath sir, Srinivas Reddy sir to give their inputs before we close for the session, sir.
For the good academic fees rather. The Kuldeep case was very good, in fact.
Thank you, sir.
Thank you, sir. Thank you, Akansha, and thank you, ASAMI India. Thank you for allowing me to present. It was wonderful and wonderful orientation of again the safe zone by Srinivas Reddy sir. That was very nice. One can start with that Ilizarov basic in at least non-transporting non-union. One can easily put in a frame.
Yes, sir. So we have to remove the fear in the exercise that putting on a Ilizarov frame is difficult in humerus or forearm. It is as easy as putting on a tibia or femur. Just a basic learning is important. So we promote everybody to get a basic knowledge of Ilizarov frame, applying, or even an LRS frame, applying in humerus, forearm, even in hand. So it's not you should get a basic training and you can do in all the cases.
And in humerus, majorly is a neurovascular bundle around the posterior and medial side. One is thorough in making that idea and the radial nerve. That two things kept in mind. They usually do not encounter a issue with the radial palsy or something, unless yes, there is a plating. You remove it, scar tissue. Sometimes there is a traction or traction palsy of radial nerve. There is that. Otherwise, putting in a pins does not endanger. If you know just the radial nerve course and the major neurovascular structure are on the medial side. Am I right, sir? Shamshul, sir. Reddy, sir.
Exactly. Basic knowledge of safe zones, basic knowledge of ring construction. That is enough. Yeah.
The radial nerve orientation is there, and the basic that the major neurovascular structure on the medial side usually do not encounter.
Yes,
yeah,
that is true.
Yeah, that is true. Yeah. Yeah.
Okay.
Great,
That,
Akansha.
yes,
Great.
sir.
Yeah. Great, Akansha. Congratulations for taking a big lead in the basics. And you have selected a very nice topic, back to basics. And the safe zones are very pertinent to your theme. And the Gowtham's case is also good. And
Yes,
Kuldeep case is very nice. And with full range of motion, even though it is a very difficult case in the multiple surgeries. Very nice. Webinar is very good. Congratulations.
No, I give credit to my teacher, Mangal Pariyar, sir. He said, when you have taken the patient, take him to his final destination.
Yeah, great.
Wherever he's coming from, send him there. Without revisit to the hospital.
Not all the time possible.
that is an attitude I had developed from my teacher, sir. That was not previously because I only didn't learn the Ilizarov, but that attitude I learned from my teacher.
Pre-injury status.
And make even though if amputation or something is needed, because we do Ilizarov, that does come. But I make sure I do not throw the patient away. I do it by myself.
Yes. You will follow totally.
Total follow. Yeah.
Total follow up.
Whether that is a thing, sometime at own cost. But sir says do not lose the patient.
Yes. Maybe a complication also you have to deal with, not to lose the patient.
Yes.
Truly. That will save the patient, that will save you also, the surgeon also.
Truly.
Otherwise, if the patient goes out, he will malcampaign.
Yeah. Sure.
Apart from risk also.
Yes.
Yes, sir.
Thank
So
you,
with that, yes, sir. Thank you so much for your presentation. Thank you, Srinivas, sir, and thank you also, Gowtham, sir, for your enlightening talks. It was a academic feast as usual. With that, I would like to request Dr. Shamshul, sir, to give the vote of thanks.
Thanks, Dr. Akansha, Kuldeep sir, Srinivas, Reddy sir, Ravina sir, for giving a wonderful talk. It was a very good session and got a real academic learning for even for us and all the youngsters. So we'll keep the light on and we'll invite you everybody to join our next masterclass series on 6th of October of limb lengthening, where we have faculties like Dr. Michael Asayag and Mangal Parihar sir, and we have Siddharth from Chandigarh. It's going to be a very good session on 6th of May. So see you all on 6th next Friday. With this, good night to all. Thank you. Thanks a lot.
Good night, sir. Thank you so much, sir. Thank you so much, respected faculty members, for joining in. Good night, sir.
Right. Good night.